My name is Mark McGovern. I'm at Stanford, and we host this group, the Center for Dissemination Implementation at Stanford, which is a NIDA P50 center. We love the collaboration with the CTN because it's a wonderful opportunity to try to infuse the best of implementation science into clinical trials and clinical trialhood. And the name of this group, I see that there's a few new people, is the CTN, which is the Clinical Trials Network from via the National Institute on Drug Abuse, Special Interest Group, SIG, Translation and Implementation Special Interest Group. So a lot of acronyms: CTN, TNI, SIG. We're not going to try to trouble you with all that many acronyms, but those are probably key ones because it's the name of the group. And we've been up and running for a couple of years, and the group ranges in kind of maybe 20 to over 100 people. I think we've got well over 100, close to 120 of people who are members. It's not an exclusive group. Once you're in, and all you have to do is sign up. And Elena has the way that you might go about doing that. So I think we do have a full agenda. We only have an hour out of respect for everyone's time. And at this point, I'll turn it over to Camille and Bryan. We did send out their bios. They're really well-established colleagues, and to have co-led this work group within the framework of the special interest group, and I think have done an amazing job of pulling together kind of a lot of information and disparate information. So I think relative to those of us that do clinical trials, this is super, super relevant work. So Camille, Bryan, it's all yours.
Wonderful. Thanks so much for having us. And Bryan, I'll let you kind of kick us off with our opening slides, and then Bryan will share a little bit of a history of the work group and how our process unfolded to get us to where we were with the scoping review. And then I'll share a little bit more about what we found. And our scoping review title is Examining Stigma Reduction via a Scoping Review, Lessons Learned from this is our presentation title, Lessons Learned from a Voluntary National Work Group. And yeah, I'll turn it over to you, Bryan.
Great, thanks, Camille. So consider me the opening act, and Camille will come in a few minutes and give you the findings from our and processes for the scoping review. But want to start by just providing a little bit of historical context, and certainly that starts with acknowledging the rest of the great many people that have contributed to the work. I think when we've presented previously to this group over the last 5 years, I've used the word communal volunteerism an awful lot, or I guess that's a phrase, but communal volunteerism, and that's what it's rested on. It's a lot of really well-meaning, well-intentioned people coming together to take on a pretty massive task, as you'll hear about later. But in terms of the people that are currently in the work group, we've got 18 members listed there, representing 13 university institutions. I've also got the CTN Dissemination Library in there, which is, I'm not sure if it's an institution unto itself. I think my colleague Meg Bruner might say that it is. But it is also based at the University of Washington, technically. But obviously, the work that's going to be presented today rests on the shoulders of an awful lot of people. I would also call out, since I see some of you here, Owen Murray in particular, that we've had a lot of people contribute to our work group over the course of 5 years. And so appreciate all of those conceptual contributions, even in the early going before we really had a work product identified to work toward. I'm not sure if I can advance these slides. Thank you. So the origin, I think Mark just mentioned this, but I'll just say, like, roughly 5 years ago, he initiated this special interest group. And initially, there were, I believe, 4 work groups, a health equity or health disparity group, an early career group, and I think the 2 groups that continue to proceed today, the implementation outcomes group that Joe Glass and I think Jennifer McNeely co-chair, and then the implementation strategies work group that Camille and I continue to lead. And I would say, like, I think in those early, maybe year and a half, it was a tricky thing in that we had an awful lot of people coming and sampling different work groups, and we weren't really sure who our members were. We were getting lots of notes from people saying, "Oh, well, I'll be there for the first 10 minutes, and then I'm going to jump over to the other work group on health disparities or on early career or whatever." Yeah, I think it was a different environment. It probably took us a little while to know who our members were, who were really going to be contributing to a work product going forward. In terms of our own work group, I would just say, you can go ahead and flash to the next slide, whoever's governing this. We are focused on implementation strategies. I think it's always useful to come back to Jeffrey Curran's infographic here. I'm sure many of you have seen this before, but when we're talking about a scoping review that's looking at implementation strategies for stigma reduction, the thing that we're talking about is stigma reduction, which arguably is a pretty diffuse thing. It's certainly more diffuse than, for instance, dialectical behavior therapy or something very concrete and focused like that. But implementation strategies are the things that we do as consultants, as TA providers, intermediary purveyor organizations, whatever our role may be, researchers, internal change agents, whatever we might be. It's the stuff that we do to try to help people and places implement that thing, do that thing. If you go to the next slide. Thanks. So we had an initial 18-month period where we really just had open meetings, I would call them, where we, a lot of like, hey, did you see this review paper on this topic? Did you see that review paper on that thing? Hey, we're at a CTN affiliate primary care setting. We'd really like to talk about the kind of implementation strategies that are relevant for our setting. Hey, we're doing this study on the opioid epidemic. We'd like to talk about that today. A lot of like kind of floating, I would say, whichever way the wind was blowing on a given day. I think they were very rich conversations, but I think that was really the purpose that was served, was really kind of a think tank over those first 18 months, talking about conceptual and methodological issues related to the science of implementation strategies. And I think at one point I said to my original co-chair, boy, I think, if we're ever going to work toward a work product, we're going to have to switch from brainstorming to really like some other strategies. And I think the strategies that were most useful were polling our members. And we did that by identifying a number of recurrent discussion topics and then doing kind of a rank ordering for what they thought the topic would be that would be of greatest interest to the members and also greatest utility to the field. That co-chair was involved with J-coin trials and I think was a big proponent of stigma reduction. And that wound up being the topic that was chosen among our work group members at that time. Go to the next slide. We also applied the same thinking to what we would do about this. We had a number of early career people, and as an unfunded entity, I think it made a lot of sense to look at how we might contribute in the form of a review paper. Some of my colleagues were more informed than I, certainly, about all the different types of review papers that exist in this day and age. And so we had one of our work group members, I'm not sure that she's here today, but Hannah Chang, who had been involved with a number of publication of several review papers. And I think that was even working, Mark, with your group there at Stanford. But she came and provided a presentation to our work group, which was very helpful and elucidating for the group. And upon that, we did another poll and really decided on a scoping review. And if you go to the next slide, you'll see that defined well. I'm actually not just relying on Hannah's good work for our work group in presenting this material. I'm actually repurposing her slides from 3 or 4 years ago. But she has a scoping review definition here, which I think is a really nice definition for that on the left side of the slide. Really highlights a conceptual synthesis of the literature and less as in a systematic review or meta-analysis of a description of research findings in detail or statistical or quantification of the findings of that research. So really relying a lot more on thematic synthesis of what the literature is saying. And that's really what the scoping review was intended to be about. If you go to the next slide. Hannah also set up a nice kind of stepwise approach for us to follow. And I think most of her stages are represented here, the 5 that were most relevant for our work. I'll highlight the top one as maybe the most important as we got started was, boy, we needed a university librarian to get involved in this because I'm not sure it would have come together if not for the later inclusion of a university librarian. But you can see that there's kind of a stepwise progression there in terms of a search strategy, of a variety of databases, initial screening process. I think that was twofold, one of screening abstracts and then a full text review, an extraction process. I suspect that Camille will say more about that in a few minutes, but a very labor-intensive data extraction process, and then a kind of a synthesis process as the paper got finalized there. So that was the kind of the stepwise approach, and again, really helpful to have members of our team or of our work group that had direct experience doing this and could provide kind of a guiding framework for us to follow. If you go to the next slide, talking about all the things that were helpful about members, but we did have challenges along the way. I think one of the primary challenges was that at one point, not long after we decided that we had a cargo and we had a destination for this train that we had created, was that our co-chair wound up leaving the work group in kind of an unexpected way. And so I think there was a period of months where we weren't quite sure how we were going to get this cargo to that destination. It was kind of like having this train on the tracks without a conductor. And so that presented some challenges. If you go to the next slide, I think we kind of attacked that in three different ways. One was, I'll credit my co-chair, my current co-chair, Camille, with stepping in and kind of serving as a de facto co-chair before we could even really provide that as a formal designation for her. But she and her student Dash, who again, I'm also not sure if she's here today, but this should be credited with some of the initial conceptual work for refining the research question and creating some inclusion-exclusion criteria to be applied to the literature. For my part, I really realized we needed a university librarian involved. Unfortunately, I have a colleague many of you probably know, Meg Bruner, as the director of the CTN Dissemination Library. She's also a member of my Northwest Addiction Technology Transfer Center team and colleague at the University of Washington. And so we got her involved. And I think that was critically important to the work, given how vast the literature was that we were going to review and the fact that we had so many people on a volunteer basis meaning to contribute to this from institutions across the country. The other piece of this, maybe the conductor, has three parts. The third piece was a software platform. And fortunately, we had members and Meg as well that really advocated for Covidence as a software platform to use to really streamline this multi-stage process for doing the review. So I think those were all critical parts. And if you go to the next slide, I think that kind of put us, some might say this conductor looks a little bit like Camille, but I think she's a critical part of it. But I think there's actually kind of three parts to the conductor. And obviously Camille is an important part of that. So too is Meg, so too is the management software that we put in place with Covidence. So felt like we got through some of those early challenges. And that didn't mean that the mountain we were climbing was any less steep, but I think it made it possible to climb that mountain. And so I think at this point I want to turn the reins over to Camille to talk about that journey and what we found at the top.
Yeah, and it was fun. Thanks, Bryan, to hear you talk about that, because I was also reflecting on where I was in my career stage. Like I had just like a year after finishing my PhD, met Noel Vest, who introduced me to the CPN implementation, just implementation science, this entity. And then I got involved in the work groups, and then things just unfolded. So I've really spent a good chunk of my early career period learning and being privileged to support leadership in this way. And so our scoping review that we eventually landed on is focused on implementation strategies to reduce stigma in healthcare settings, which is timely. And I'll also share sort of from a background perspective that there are several other systematic reviews out there that focus on this topic, or at least stigma in healthcare settings broadly, and interventions that have been conducted. But we really saw an opportunity to fill some gaps in the literature around the implementation strategies that were used, because people weren't really looking specifically about how these programs were being implemented. They were looking at maybe whether they worked or whether the measurement was rigorous or not, but not understanding like how to delineate what was going on. And so just to take a step back, I don't think any of this is going to be surprising to any of you. Over the past 5 years or so, there has been so much attention to stigma at NIDA, and I think that's part of the reason why our work group ended up focusing on stigma in this way. But we know that stigma exists at multiple levels, the sort of internalized individual level, the interpersonal level that happens, with the sort of stigma making, and also there's intersecting stigmas. And then it kind of goes also up into this structural level where people enact stigma in healthcare settings, either through these interpersonal interactions and the way that they treat patients, or through the more and the policies. And for I do a lot of prenatal postpartum work as well. So thinking about things like unnecessary urine drug testing is an example of enacted stigma. And so, we know that this has impacts on care and the care that people receive and their willingness to seek care. So we know that only 7%, and I think that there's some different fluctuating numbers, but essentially we know that a very small proportion of those who need substance use disorder treatment and other services receive it annually. We also know that negative attitudes, so the stigma that's enacted, reduces empathy, engagement, and quality of care for patients. And we also know that when we can use strategies to reduce stigma, we can improve equitable, compassionate, and evidence-based SUD care, at least in theory. I will say that there's been I think all of us see this to be true in whether it's research or practice in the way that our things unfold, though there hasn't been a lot that looks at whether intervening on stigma predicts clinical outcomes, which is an area of future research that I should probably save for later, but I'll just share that now. So in terms of our research question, we asked, how have effective interpersonal or structural stigma reduction interventions been implemented in healthcare settings? And I will say that we loosened that word effective pretty a lot in the course. This was sort of our original research question. And we just asked generally, how have interventions to address interpersonal or structural stigma been implemented in healthcare settings? And we took a very broad approach, and I'll talk a little bit about purpose and methods. And so we really, we wanted to be as inclusive as possible, but we did have some things that we narrowed in on, and I'll talk about our inclusion and exclusion criteria, I think, a little bit more specifically on the next slide. But we looked at, okay, here's a variety of healthcare settings. So we were really broad in that approach too. It could be, clinicians in training or other healthcare professionals in training. It could be primary care, emergency departments, specialty settings like obstetrics. So we just said any healthcare setting, give us any healthcare setting, and give us any substance use disorder except for nicotine. I believe I know for sure we excluded nicotine, and I don't think that there were others that we excluded, but we also focused on, not prescription medications, if you will. So we didn't focus on medication for opioid use disorder stigma per se, although of course that was sort of woven into some of the stigma interventions that we examined. We followed the PRISMA guidelines and searched across multiple databases. As Bryan said, Meg was critical we could have not done this without Meg. I can't underscore enough how important having her support was. And we also excluded self-stigma, we excluded observational studies, and we also used a implementation strategy framework. So we used the ERIC taxonomy, and I'll talk a little bit about how we needed to adapt that slightly to make it pragmatic for the way that we were extracting data. So here's a list of our inclusion exclusion criteria. So we, focused on English language articles only, articles that were focused in the United States. We originally were more expansive than that, but then we were kind of looking at healthcare systems are different. Our United States healthcare system is different than other healthcare systems, and so we thought that was a good rationale for focusing in the United States. We also focused on recency, so articles published in since the year 2000 to the present, just based on the shifting historical patterns in substance use and the contemporary way that we're thinking about stigma. And then we also we didn't necessarily have any population-specific focuses. We looked at healthcare settings and healthcare personnel, structural or interpersonal stigma only, as I mentioned. And then our study outcomes were interesting to sort of conceptualize. We were really broad there as well. And sometimes we really had to take time to look at the measure that was used because there are standardized measures that exist, like the opening mind scale, but not everybody uses those. Sometimes people create their own scales that focus on, people's attitudes towards people who use drugs or with substance use disorders. And so we kind of really focused broadly on stigmatizing beliefs or behaviors, attitudes or beliefs or behavior, and mostly those things focused on attitudes versus behaviors, I would say. And then in terms of study design, we did not include observational, case control, or individual case reports. And we also excluded commentaries, editorials, policy documents, protocol descriptions, lit reviews, and meta-analyses, but we did tag those things so that we could take a look at them later for some of the background information. So I mentioned before that we needed to adapt the ERIC Evidence Now categories related to implementation strategies. And we have a table that appears in our manuscript that shows how we did this. And so you can see on the left, and I won't go over all of these, but I'll tell you kind of how we adapted them broadly. On the left is what we ended up using in our scoping review. And on the right is how they were adapted from the Evidence Now category. And so you can see that we kind of created an overarching sort of theme called train. So training, these were training strategies. And then took them from there was strategies to train and educate stakeholders was the Evidence Now category. And most of these fell in here, but what we found was some of them were either more specific than others, or some of them kind of packed in multiple strategies within a definition. So we tried to really just make sure that there was sort of an equitable level, if you will, within the training categories. The other thing that we added that I think is an innovation and important to note, given the way that we are doing our work as researchers and as practitioners, is that we added an entire sort of subcategory called consumer contact. And so in the Evidence Now categories, there are strategies that are called, that they call sort of consumer involvement in implementation, but that usually looks like, my favorite example is I go to the doctor's office now, and sometimes there's signs that say, ask your provider if they remembered to wash their hands. So that's an example of how a consumer would be involved in the implementation. They're serving as a reminder to the clinician to implement this hand washing intervention. But consumer contact is different. Consumer contact is when part of the intervention that's happening around training before the intervention is even rolled out is that you're talking to people with lived experience about their experiences to reduce stigma. And we see this as an evidence-based strategy to reduce stigma. And so, and we see it all the time too. If you've, I have relatives who are nurses, and part of their training is often to attend a mutual aid group like an Alcoholics Anonymous group in the community. So that would be an example of consumer contact. So we added those as strategies. We also have this sort of purple group, which is more like ongoing support. And you can see again how we a lot of them were very similar and mapped on almost exactly And then here's that engaged consumers group that I mentioned before. And then, and this you can see as like a co-design up front, which again is different, I think, than the consumer contact piece. And then some other strategies as well. And we really wanted to focus on those trained strategies because we knew that that was mostly the way that stigma interventions were being delivered. And so we had these sort of lumped as a, other strategies and then delineated the trained strategies in our scoping review findings. Here, as Bryan mentioned, so this was a really intensive process. This is what our extraction template looked like. I would say too that we used Proctor's sort of way of specifying implementation strategy. So for each strategy that was used, we went through and talked about or delineated like the temporality. So did it happen first, second, third, fourth, fifth? Did it who was the actor that was facilitating the strategy? All of those pieces, which we ended up not being able to really like incorporate all of them, but we have so much data on the implementation strategies and the ways that they were used. But that was a good lesson learned for us too, of trying to think about how do we synthesize all of the data that we collected. And then in terms of our results and findings, here is our Prisma table. And so this, so our articles, we went through 2023, and then we searched PubMed, PsycInfo, Web of Science. We ended up removing 2002 references. Some of those were with the duplicates that we found, or Meg found, I should say. We screened as a group almost 5,000 studies. And so that included, I would say, at least 10 work group members who were going through abstracts and screening to make sure that they met our inclusion criteria. We excluded a lot of studies in that process, and that also, included not just the abstract screening, but the full text review process as well. And so I think I can't remember how many we ended up with but there were still a lot of papers to screen to get to the full text review process. Mostly, I would say, because of the ambiguity around whether they were measuring stigma reduction as an outcome because of our broad inclusion criteria around that specific piece. And then you can see why we excluded studies over on the right. Wrong year, wrong country, wrong outcomes, gray literature, systematic review. These are all some of the things you can see. There's a lot of wrong study design. There was a lot in here. And then ultimately, we ended up with 118 studies included in our review, which is still a large scoping review based on some definitions that I found recently in a group defining what a large review paper would be. Okay. In terms of the intervention types that we found, so we found about 5% were social contact interventions, 17%, and we tried to create discrete intervention type categories after we had gone through all of the data. And so these were the categories that we kind of found. And so some of these obviously have a little bit of overlap. Like, for example, expert interventions are going to include information most likely around follow-up care related to alcohol and opioids. But we wanted to focus on what the primary purpose of the intervention was. And so we had social contact interventions. Like, the goal was really just to help immerse people in understanding lived experience of people who are struggling with substance use disorders, policy intervention. So there was one study focused on prescription drug monitoring programs, and they looked at stigma as a byproduct, for example, finding that it increased stigma. Alcohol-focused trainings, where it was really focused on how do you support people and treat alcohol use disorder, opioid use disorder focused trainings. And then there were some that focused on both of those together, and those were medication for addiction treatment trainings, ESPERT, and then these organizational ones. You can see the breakdown where ESPERT was by far the most common, along with opioid use disorder. And some organizational, much fewer social contact interventions as the sole focus. And this, I think, really reflects the current climate that we're in with so much energy and focus toward opioid use disorder in particular. Here are the settings. So we looked at the settings where the training occur and the practice in settings where they were intended to be implemented. I'll just show you the training setting today, but I don't think that this should be surprising to you all that higher education was the primary setting. So people in medical school, and then sort of the next step after that, hospitals and teaching hospitals were the other most common training setting, but by far people who are receiving sort of this foundational education were the ones most likely to receive a stigma reduction intervention. And what's interesting is there are some other studies that demonstrate that trainees are perhaps more positively influenced by stigma reduction trainings. And so the lack of intervention in these other settings is likely a missed opportunity. And so I mentioned this already, most are occurring in these academic healthcare settings. And then I would say too, the most common implementation strategy that was used were these educational meetings and training materials. So like you would imagine, a professor teaching a course or somebody coming in to teach a 6-week, short-term course or even a one-time training, focusing on this sort of more dyadic, just I'm going to present some information to you and here are some materials. That was the most common way that these interventions were delivered. While our focus really was not on outcomes and the way that those were measured, and other reviews have mentioned this in the past, there were a lot of methodological limitations in the studies that we reviewed. Again, this is known. A lot of just pre-post, no control groups, or sometimes even post only. We also included qualitative studies as well, because our goal really was to be really broad and thinking about how is the field thinking about addressing stigma. And so there is so much need to do more work here to really focus on what, really being clear about what we're implementing, how we're implementing it, and then looking at how that impacts stigma, and then even taking that a step further, using a validated scale, first of all, and then taking it a step further to see if addressing stigma itself is actually driving clinical care in a positive direction, or what other aspects of the training and the implementation strategies used could be driving that care. So really nice implications for hybrid designs. And I think in general, there's some mixed information. So looking at SBIRT as an example, we can't really be sure about our patterns of findings and how those are predicting our outcomes. But we know that when we're looking at the data, it seems to suggest that when we're just doing education only within like an SBIRT model, that might not be enough to address stigma, that there needs to be some of these other more experiential components, whether that's social contact or role plays or opportunities to address the stigma or bias that might come up in a more focused way. There's these sort of stimulation exercises and social contact interventions we know can foster empathy, but are underutilized as well. But again, without randomized trials that are focused on implementing these different strategies, we don't know for sure that that's going to make a difference. We need these really robust hybrid studies to find out. And then they're also sort of at the organizational and policy level, there's some strategies or some interventions that we're using these organizational level strategies, like focusing on organizational change. So for example, one way you can reduce stigma in an organizational setting would be to teach people how to have positive sort of strengths-based conversations behind closed doors about their patients. So instead of being like, oh my gosh, this person is like so non-compliant, we're not, they're never going to go anywhere. This is a lost cause, focusing on more of the like, they're having some hesitancy now, but I'm working really hard to help come alongside them to encourage them to change this behavior, or talking about things that have worked well in the past, or highlighting stories of success and hopefulness toward the mindset that people are, when adequately supported, can make positive changes. And so there's sort of these missing opportunities for system or even incentives to insurers. We didn't see a lot of this, and it could be because our search strategy or our review process, maybe they were there, but we just kind of missed them in the way that we were thinking about things. But thinking about insurance, insurers, payers, and how they incentivize different practices could be another opportunity for intervention. Some of our limitations, so these were limited to English language peer-reviewed literature, and the scoping review doesn't include quality appraisal. So, like I said, lots of opportunities to improve the quality of these studies. We had to make decisions about whether something was a stigma intervention, and that required a lot of interpretation when we were trying to be more broad in our approach. Most studies were small, pre-post, and really short term, and outcomes focused on attitudes, not behavior or systems. And so our future directions and conclusions, we need more rigor, we need hybrid designs. I think there's also some implications for adapting ERIC just slightly to be more, to improve the specificity, to also help us replicate. So when we do have a strategy that works, making sure that we have, a clear understanding of what that strategy was, especially related to social contact interventions. We also need to think about expanding our reach and our settings once we know it works, at least, or at least expanding our settings when we are trying things too. So thinking about primary care, obstetrics, mental health, things that were missed opportunities in the literature that we reviewed, at least. And then sustainability. So how do we, continue to think about how if we have a one-time training or an educational opportunity, that might not be enough for sustained change. And here's our question or contact information. And Bryan, I know I talked quickly and wanted to leave time for questions, but if I missed anything or other members of the work group that want to say anything else about their reflections, please feel free. And any questions as well.
Really, really nice job, Camille and Bryan, presenting. And Bryan, I loved how you got it started, how you were able to assemble a really diverse group of people from across the country and various disciplines and roles and managed to actually get work done within the context of a work group, which is there might be a worthy presentation on how to do that in and of itself. So I guess congratulations to both of you. And I know you're actually working on a manuscript to publish this work, but I think it's super important. And I guess I just wanted to open it up to the group to see if people have questions about this or comments about this issue. Maybe I'll. Oh, I see a hand from Dr. Mari.
Good afternoon, all. Can you hear me?
Yes.
Okay, thank you so much. One quick question, as I put in the chat, I'm the commissioner of a local health department in Monroe County, so Finger Lakes region of New York State. Everyone come visit. It's beautiful and it's not crowded like New York City. We have a addiction services team that is funded by opioid settlement dollars. And so in your implementation strategies, or in the settings that you all came across, did you find much published about work done by departments of public health, local health departments?
I can't think of any, but I'm wondering if others can recall. We had so many studies, Crystal or Bryan or let's see, Noel, anybody else who was reviewing. Do you remember any that were
I don't
focused?
remember any specifically.
No.
I might suggest that maybe an addition or a supplement to the work that you've already done, maybe explore that topic because, at least in the state of New York, so many local health departments have received opioid settlement dollars. And as non-academic entities, we have sometimes different connections to community, and we just can do different things than maybe specific academicians or some of our colleagues who work in a clinic setting and have to generate enough RVUs to keep the lights on, right? So the Monroe County tax dollars fund a lot of the work that my department does outside of the opioid space, but there is a lot of good work being done by my addiction services team and other colleagues across the country. And so that's a really rich partnership that has developed between us and our academic colleagues at the University of Rochester, Medical Center at Rochester Regional Health. Fortunate enough to only have to deal with 2 health systems in my county, so it makes it a little bit easier. But there are a lot of folks doing really creative things, and selfishly, I would love to see what some of my colleagues are also doing. So just another interesting aspect to consider to contribute to this work. But thank you for pulling this all together because we, not being particularly grant funded, we often poach a lot of ideas from our academic colleagues and see what fits and what we can do as government entities. But thank you for this work. Really appreciate it.
Yeah,
Thank you
thank
for your
you.
comments. And I think it was noted, as was noted in the chat by Crystal, one of our members, there is a publication bias here, obviously. But I do wonder if organizations like yours, if we think about something like a scoping review that's meant to be a conceptual synthesis, I wonder if more authors of scoping reviews ought to be, reviewing websites or other things other than published literature to have a better sense of what has been developed out there. It certainly is congruent with the idea of a scoping review that's doing a conceptual synthesis where we do not necessarily need to know like what the finite outcomes were of particular strategies, but what was tested and what was the approach taken.
And certainly, if you wanted to address it, there are every state has its, we have the New York State Public Health Association, we have the New York State Association of County Health Officials. So every state has their group of local health department leaders. Of course, we live in a federation of states, so each state is different, but I certainly think it would be really, really interesting and eye-opening to look into whatever different states have as another source of sometimes just different, interesting approaches to how to address stigma.
Yeah, and I think the thing that would be the most similar, as I was thinking about this, is the ECHO model that that certainly came up in our search, and so these sort of educational, like statewide initiatives that are often, they're often focused. They have sort of a hub, like in Oregon, we have OHSU, who's facilitating these ECHO learning collaboratives, and they collaborate with our health authority. And certainly like public health campaigns, but those would be focused more on the individual level. But I think that there are so many things. And I think that also is a recency bias too, right? Our cutoff was 2023, and that we've seen so much additional work focused, as you mentioned, especially with the opioid settlement funds. So it's a great point, and a good point for our limitations. If our reviewers point out that we need to add more of them in the review process. So thank you for that. Any other? Yeah, go ahead.
I say great comment, question, suggestion. Other questions or comment?
Hi, it's Reed Finlayson. It's really been a pleasure for me to be associated with the group. I'm not really a researcher, basically a clinician, but my comment would be that it's very difficult to evaluate stigma without going back to what the cause of the stigma is. And the cause of the stigma goes back to the years of 1914 to 1919, before which doctors actually were able to manage addiction very successfully. That's been published in the New England Journal. And unfortunately, what happened is that they started putting people in jail for being addicted, and then persecuting doctors, thousands and thousands of doctors, for trying to help these people. And then it was all reenacted in 1970 in the Controlled Substances Act, which is just impossible, and made things worse. And we have the distinction in this country of having the highest rate of incarceration in the world, and most of that is due to people who have substance use disorders that are seen as criminal rather than medical problems. I could go on, but it's it's very frustrating.
Yeah, it's important and critical point to make, Reed, and I think especially in the current context. And sometimes it can feel really, this is our small contribution, and sometimes it can feel like, we're going backwards in a sense. And I was reminded by a mentor that we just continue to participate in the struggle of focusing on what we know as evidence-based as scientists. And so I appreciate you all being here, willing to learn and participate in that way too. And thank you for noting that, Reed.
Thank you.
Other questions, comments? That's great, Reed. Thank you. I was thinking all too often, we do clinical trials, and we engage with study sites, organizations, clinics, and so forth, and we have recruitment goals, and we want the study site to help us achieve the recruitment goals. And lo and behold, we find that for whatever reason, that's not happening. So, we often do some, we try to sell it a little bit better. We try to maybe even move on to another study site so that we can meet our recruitment goals. And it occurs to me that, stigma might be a pretty significant driver in, some of the problems that come up between a researcher and a study site. And it's not anything that we typically measure. Maybe we do try to explore via our relationships or contact people, study site coordinators, but it seems to me that stigma might be a huge driver, kind of a subterranean, maybe invisible driver. And we think about, the nature of our work, always wanting to leave a place better than when we found it. At least that's our philosophy, our mission. And it's not only leaving better interventions behind, but maybe it's about leaving better attitudes behind. So I really think that if there are stigma busting, demythologizing interventions that are available, or as you guys put it, implementation strategies, we ought to know about them, and we ought to try to be using them within the context of our research. And it seems like that would go far to help the whole issue.
Mm-hmm. That's a great point. And it brought up, I think, two things, Mark, that one is being able to measure stigma as a secondary outcome when we're working in these settings too. I think we could contribute to the field. It reminds me of an early publication that I had focused on accelerating the pace of science, where we can do these sort of implementation studies and be focused on these additional important secondary outcomes at the same time, so we can advance the field more rapidly. And the other thing that you said about mechanism made me think about, I'm thinking about interventions that enhance motivation to change, and maybe those stigma interventions could also enhance organizational readiness to change, or practitioner willingness to change. And that could be a really nice model to assess in future research studies, to think about, do we need to address stigma before we try to be implementing a new practice in a setting, so that people are more willing to uptake the intervention if they see it aligned with those values. So thanks for that.
Thanks to you both, and thanks for the team. I see there's a number of people who are part of the work group that are here, and we're grateful to all of you for your good work. And I guess it does lead into the next item on the agenda, which is the work group report out, and we heard some significant report out from the Stigma Implementation Strategy Work Group. But I'm looking out and seeing Cioffi, Joe, and Jennifer, for example, from the Implementation Outcomes Work Group. So maybe we can just sort of check in with you guys and see if there's any updates. And one thing we always mention is that the work groups are wide open, so there's always room, for new members, new volunteers. Bryan, I forget what you called the volunteerism. There was a term you used. I thought that was excellent. Of course, I forgot it already.
Communal volunteerism.
So, communal volunteers, nice, good. So Jennifer, Joe, Cioffi, any updates from the implementation outcomes work group?
Yeah, we can give a status update. Jennifer, do you want me to start and then others can jump in too?
Yeah, if you don't mind. Thank you.
Yeah, no problem. Yeah, good to see you all. Great presentation. So the implementation outcomes work group. So just as a reminder, our initial goal is to identify the current state of implementation outcomes, measurement, implementation science within the CTN. And so we wanted to do that as a means for recommending best practices for future CTN research. And really our main product was a manuscript article recently published led by Cioffi involving all of our work group. In terms of where we're at today, so that article was published at the end of last year, and we met in December to talk about future directions of our work group, kind of what's next. And so this kind of led to some discussions about opportunities. One of the main findings of the review was there's been kind of a lack of focus on implementation outcomes measurement and implementation science generally in like comparing health disparity populations and success in those studies. So a lot of work group members were really interested in that. One potential way that we could follow up on that we discussed is Cioffi expressed interest in presenting to other parts of the other work groups in the CTN, such as there's a sex and gender differences SIG, so that could be one venue where we try to reach out and see where does our work intersect with the rest of the CTN and especially in regards to our work group member interests. We let's see. We also heard some good updates from the CCTN from about basically new kind of data sources being produced that could help with future reviews of being conducted by members of this SIG. So, for instance, they're doing their own portfolio analysis of CTN studies, which likely can find. They've classified studies in their own ways. So that could be a data source used for future reviews of what's going on with CTN. So we really want to also connect with, and Jennifer, maybe you could talk about this, but we're trying to figure out how we can potentially discuss, like, how might we want to merge with the strategies group? Really, what does our formation look like moving forward? And then last, as a co-lead, I'm looking to rotate off that position. So potentially finding a replacement for me to work with Jennifer, and or maybe we don't have to if we decide to if merging is the best approach moving forward. So yeah, that's Jennifer. Anything else you want to say?
No, thank you for the summary. I don't have much to add except to say, like, we're happy that we sort of accomplished our first goal of doing this review, and the group is, I think, interested in continuing to gather, but we're not wedded to keeping it as the implementation outcomes group if there's a better way to contribute.
Well, that's great. I think Joe, you touched on the CCTN, and we know that Povo and Sabe have also been talking with us about the data that they've sort of been warehousing based on all the CTN protocols from day one, and are interested in this group's kind of input and really guidance on how to make sense of those protocols, both historically and also, I think, as a vision for the future and a commitment to translation and implementation. So I do think, to some extent, the SIG is at a pivotal place, being able to partner with the CCTN. So we're going to be meeting with them, I think, in the next couple of weeks, and maybe invite them to come to this group and kind of share how they see things, and maybe help us sort of think about opportunities, to kind of coalesce different groups. Outcomes being one of them. I think strategies being another one, and the team we just heard from focused on strategies and just happened to pick one dealing with stigma, but there's a whole lot of other ones that are probably involved in clinical trials that people don't even acknowledge or mention. And then there's this whole business of context and sustainment, I suppose, too. How, to what degree are interventions studied and found to be effective, sustained in the places where all of that happened. So I think that there's a lot of room for us. But the work groups also are, I think we're also open to ideas about new work groups. So if people have ideas, you can let Elena or me know, and we can sort of post a flag and see who else might be interested in being part of that. But I want to respect everyone's time. This hour goes fast, as always. Always feels like I'm kind of rushing. But really appreciate everyone today, and hoping you all have a good 2026. Forgot to wish you all a happy new year. It's been off to quite a rousing rumble of a start for many of us. But I'm optimistic it's going to be ultimately a good year. So next meeting is Tuesday, March 17th, 9 a.m. Pacific. That's noon Eastern, St. Patrick's Day, I think that's right. So we'll see you all in a couple of months, and reach out if anything occurs to you in the meantime. Thanks, guys.